Hey everybody, welcome back to Drug Talk. As always, my name is Garrett Campbell. In today's video, we're going to be going through the monograph for Escitalopram or Cipralex. And the monograph we're going to be using today is the Sandoz generic brand monograph. All the monographs would have the same information in them. We just chose this one kind of randomly. But like I said, let's jump right into it, going through the full monograph, and I'll also chop up some bits of this long version video into smaller bits and post them on the channel. So again, we're going through Sandoz Escitalopram here. This is the monograph. Cipralex, you can see here, it's available as 10 milligram and 20 milligram. And we'll just skip through the table of contents here and bring us right down to indications and clinical use. So in adults, Escitalopram or Cipralex is indicated for the symptomatic relief of major depressive disorder or MDD. The efficacy of Escitalopram oxalate in maintaining an antidepressant response in patients with major depressive disorder who responded during an 8-week acute treatment phase while taking Escitalopram and were then observed for relapse during a period of up to 36 weeks, was demonstrated in a placebo-controlled trial. So Escitalopram is indicated for the symptomatic relief of obsessive compulsive disorder, or OCD. The obsessions and compulsions must be experienced as intrusive, markedly distressing, time-consuming, or interfering significantly with the person's social or occupational functioning. The efficacy of Escitalopram in maintaining an anti-obsessive response for up to 6 months in patients with obsessive-compulsive disorder was demonstrated in long-term placebo-controlled trial in patients who initially responded to 16 weeks of Escitalopram in open-label treatment. Physicians who elect to use Escitalopram for extended periods should periodically reevaluate the usefulness of the drug in individual patients. Now, what about geriatrics? So patients over 65 years of age. So elderly patients should be administered lower doses and a lower maximum dose. For pediatrics, so 18 years or less of age, it is not indicated for the use in patients below the age of 18. So now contraindications. So Escitalopram is contraindicated in patients with a known hypersensitivity to Escitalopram or any excipients of the product. This is kind of standard for every medication. It is contraindicated in patients with known QT interval prolongation or congenital long QT syndrome. And then we have medications here. So monoamine oxidase inhibitors or MAOIs. So cases of serious reactions have been reported in patients receiving selective serotonin reuptake inhibitors or SSRIs, so that would be Cipralex, in combination with a monoamine oxidase inhibitor or a reversible monoamine oxidase inhibitor, which is a REMA, meclobamide, and in patients who have recently discontinued an SSRI and have been started on an MAOI. With the co-administration of an SSRI and an MAOI, there have been reports of serious, sometimes fatal reactions, including hyperthermia, rigidity, myoclonus, autonomic instability with possible fluctuations of vital signs. The mental status has changed in some individuals, including extreme agitation, progressing to delirium and coma. Some cases presented with features resembling serotonin syndrome. Therefore, Escitalopram should not be used in combination with an MAOI or within 14 days of discontinuing treatment with an MAOI. This includes linezolid, which is an antibiotic, which is a reversible non-selective MAO inhibitor, MAOI, and methylene blue, which is an MAOI. Similarly, at least 14 days should elapse after discontinuing Escitalopram or Cipralex before you start an MAOI. We also have pimozide here. So Escitalopram should not be used in combination with the antipsychotic drug pimozide as a result from a controlled study with racemic citalopram, that would be Celexa, indicate that concomitant use is associated with an increased risk of QTc prolongation compared to pimozide alone. So pimozide cannot be used with escitalopram or citalopram, so Cipralex or Celexa. We'll now move into warnings and precautions. So general, potential association with behavioral and emotional changes, including self-harm. So pediatrics. So placebo-controlled clinical trial data suggests. So recent analysis of placebo-controlled clinical trial safety databases of SSRIs and other newer antidepressants suggest that use of these drugs in patients under the age of 18 may be associated with behavioral and emotional changes, including an increased risk of suicidal ideation and behavior over that of placebo. The small denominators in the clinical trial database, as well as the variability in placebo rates, preclude reliable conclusions on the relative safety profiles among these drugs. So adults and pediatrics, additional data. There are clinical trials and post-marketing reports on SSRIs and other newer antidepressants in both pediatrics and adults of severe agitation type adverse events coupled with self-harm and harm to others. The agitation type events include akathisia, agitation, emotional lability, hostility, aggression, and depersonalization. In some cases, the events occurred within several weeks of starting treatment. Rigorous clinical monitoring for suicidal ideation or other indicators of potential suicidal behavior is advised in patients of all ages. This includes monitoring for agitation-type emotional and behavioral changes. The FDA meta-analysis of placebo-controlled clinical trials of antidepressant drugs in adult patients aged 18 to 24 years with psychiatric disorders showed an increased risk of suicidal behavior with antidepressants compared to placebo. So the general thing here is when you use an SSRI, there is an increased risk compared to placebo for behavioral changes, including suicidal behaviors. Discontinuation symptoms. So patients currently taking escitalopram should not be discontinued abruptly due to the risk of discontinuation syndrome. At the time that the medical decision is made to discontinue an SSRI or other newer antidepressant drug, a gradual reduction in the dose rather than an abrupt cessation is recommended. So escitalopram or Cipralex, treatment during pregnancy, effects on newborns. So in animal reproductive studies, escitalopram has been shown to have adverse effects on embryo or fetal and postnatal development when administered at doses greater than human therapeutic doses. There are no adequate and well-controlled studies in pregnant women. Therefore, escitalopram should be used during pregnancy only if the potential benefits to the patient justifies the potential risks to the fetus. Interference with cognitive and motor performance. So in a study with healthy volunteers, racemic citalopram, so again this is Celexa, this is not Cipralex, but they're very similar, did not impair cognitive function or psychomotor performance. However, psychotropic medications that impair judgment, thinking, or motor skills, they may. Consequently, patients should be cautioned against driving a car or operating hazardous machinery until they are reasonably certain that escitalopram does not affect them adversely. Now, what about bone fracture risk? So, epidemiological studies have shown an increased risk of bone fractures following exposure to some antidepressants, including SSRIs and SNRIs. The risks appear to be greater at the initial stages of treatment, but significant increased risks were also observed at later stages of treatment. The possibility of fracture should be considered in the care of patients treated with escitalopram. Elderly patients and patients with important risk factors for bone fractures should be advised of possible adverse events which increase the risk of falls, such as dizziness and orthostatic hypotension. Orthostatic hypotension would be a sudden drop in blood pressure when going from a seated to a standing position, especially at the early stages of treatment, but also soon after withdrawal. So for the precautions, I don't think it will be helpful to go through each precaution, but we'll go through the list, and any ones that jump out, we'll take a read through them. So patients with cardiac disease, so neither escitalopram nor citalopram has been systematically evaluated in patients with a history of myocardial infarction or heart attack or unstable heart disease. Patients with these diagnoses were generally excluded from clinical trials during the drug's pre-marketing assessment. So in line with other SSRIs, including citalopram, escitalopram causes statistically significant but clinically unimportant decrease in heart rate. So in patients less than 60 years old, the mean decrease with escitalopram was approximately 2.3 beats per minute, while in patients greater than 60 years old, the mean decrease was approximately 0.6 beats per minute. Consequently, caution should be observed when escitalopram is initiated in patients with pre-existing slow heart rate. We'll skip over QT interval prolongation. Let's see what they have to say about diabetic patients. Neither escitalopram nor citalopram, so they haven't been evaluated either. Rare events of hypoglycemia were reported with citalopram. Treatment with an SSRI in patients with diabetes may alter glycemic control. So hypoglycemia and hyperglycemia, high blood sugar and low blood sugar. Citalopram should be used with caution in diabetic patients on insulin or hypoglycemic drugs. In terms of abnormal bleeding, so SSRIs and SNRIs, including escitalopram, may increase the risk of bleeding events by causing abnormal platelet aggregation. Concomitant use of ASA or non-steroidal anti-inflammatory drugs such as Advil or warfarin and other anticoagulants may add to the risk. So case reports and epidemiological studies have demonstrated an association between the use of drugs that interfere with serotonin reuptake and the occurrence of gastrointestinal bleeding. So bleeding events related to SSRIs and SNRIs use have ranged many different things, all the way up to life-threatening hemorrhages, down to just small bleeds. So patients should be cautioned about the risk of bleeding associated with the concomitant use of escitalopram and NSAIDs or ASA or other anticoagulant medications. Let's see what they have to say about hepatic or liver impairment. So based on a study conducted with escitalopram in patients with mild to moderate hepatic impairment, the half-life was approximately doubled and the exposure was increased by approximately 2/3 compared to subjects with normal liver function. Consequently, the use of escitalopram in hepatically impaired patients should be approached with caution and at a lower dose. So no information is available about the pharmacokinetics of escitalopram in patients with severe hepatic impairment. Escitalopram should be used with additional caution in patients with severe hepatic impairment. We'll skip over seizures, and neuroleptic malignant syndrome, and serotonin syndrome. Glaucoma, as with other SSRIs and SNRIs, escitalopram can cause mydriasis and should be used with caution in patients with raised intraocular pressure or those with narrow angle glaucoma. Okay, so this is an important point here. So suicide/suicidal thoughts and clinical worsening. So depression is associated with an increased risk of suicidal thoughts, self-harm, and suicide, or suicide-related events. This risk persists until significant remission occurs. As improvement may not occur during the first few weeks or more of treatment, patients should be closely monitored until such improvement occurs. It is general clinical experience that the risk of suicide may increase in the early stages of recovery. Therefore, high-risk patients should be closely supervised throughout therapy with consideration to the possible need for hospitalization. In order to minimize the opportunity for overdosage, prescription for escitalopram should be written for the smallest quantity of drug consistent with good patient management. Other psychiatric conditions for which escitalopram is prescribed can also be associated with an increased risk of suicide-related events. In addition, these conditions may be comorbid with major depressive disorder. The same precautions observed when treating patients with major depressive disorder should therefore be observed when treating patients with other psychiatric conditions. So this one, personally, I find, as a patient who has bipolar himself, I find this one personally interesting. So I'll read through this one. Activation of mania and hypomania. So in placebo-controlled trials of escitalopram, activation of hypomania, or mania, was reported in one patient of 715 treated with escitalopram, and in none of the 592 patients treated with placebo. Activation of mania or hypomania has also been reported in a small proportion of patients treated with citalopram and with other marketed antidepressants. As with other antidepressants, escitalopram should be used with caution in patients with a history of mania or hypomania. A major depressive episode may be the initial presentation of bipolar disorder. Patients with bipolar disorder may be at an increased risk of experiencing manic episodes when treated with antidepressants alone. Therefore, the decision to initiate symptomatic treatment of depression should only be made after patients have been adequately assessed to determine if they are at risk for bipolar disorder. Now, speaking about the kidneys, so hyponatremia or low sodium, as with other antidepressants, cases of hyponatremia or SIDA, syndrome of inappropriate antidiuretic hormone secretion, have been reported with escitalopram and racemic citalopram as a rare adverse event. So again, a rare adverse event. The majority of these occurrences have been in elderly individuals, some in patients taking diuretics or who were otherwise volume depleted. Elderly female patients in particular seem to be a group at risk. Caution should be exercised in patients at risk, such as elderly or patients with cirrhosis, or if used in combination with other medications which may cause hyponatremia, low sodium. What about renal or kidney impairment? So no information is available on the pharmacokinetics or pharmacodynamic effects of escitalopram on patients with renal impairment. Based on information available for citalopram, no dosage adjustment is needed in patients with mild to moderate renal impairment. Since no information is available on pharmacokinetics or pharmacodynamic effects of either citalopram or escitalopram in patients with severely reduced renal function, escitalopram should be used with caution in these patients. What about nursing women? So studies with escitalopram have not been performed in nursing mothers, but it is known that citalopram is excreted in human breast milk. And it is expected that escitalopram is also excreted in breast milk. Escitalopram should not be administered to nursing mothers unless the expected benefit to the patient outweigh the possible risk to the child, in which case the infant should be closely monitored. So we already touched on pediatrics and geriatrics. All right, so we're now discussing adverse events or side effects. So adverse drug reaction overview. So adverse events information with escitalopram was collected from 715 patients with major depressive disorder who were exposed to escitalopram and from 592 patients who were exposed to placebo in a double-blind placebo-controlled trial. During clinical trials, all treatment groups were comparable with respect to gender, age, and race. The mean age of patients was 41 years old. The range was 18 to 76. Of these patients, approximately 66% were female and 34% were male. The adverse event information for escitalopram in patients with obsessive compulsive disorder was collected from 2 studies with double-blind, placebo-controlled treatment over the period of 24 weeks. In the first study, a total of 227 patients were exposed to escitalopram and 114 to placebo in a 24-week double-blind, placebo-controlled, fixed-dose trial with assessment at 12 and 24 weeks. So right here, they're just explaining how the trials were conducted for OCD and for major depression, but we're not actually into the side effects yet. Okay, so adverse events observed in control trials. So adverse events associated with the discontinuation of treatment. So from a short-term, 8-week placebo-controlled phase 3 studies in patients suffering from major depressive disorder, the incidence of discontinuation was 17.3%. So 124 of 715 patients discontinued the medication. Discontinuation due to adverse events was more common in the active treatment group. So 5.9% escitalopram and 5.4% in the citalopram group, and only 2.2% in the placebo group. So more people stopped taking the medication than the placebo due to side effects, which is to be expected. The events that were associated with discontinuation of escitalopram in 1% or more of patients at a rate of at least twice of that of placebo. So these are the main things that were causing people to discontinue taking escitalopram. So nausea, there's 1.5 versus 0.2%, and ejaculation failure. During the first 12 weeks of treatment, in the 24-week placebo-controlled trial, discontinuation of treatment due to adverse events was reported for 9% and 11% of the 227 OCD patients who were treated with 10 milligrams per day or 20 milligrams per day of escitalopram, respectively, compared to 5% of the 114 patients receiving placebo. So all patients who discontinued treatment due to adverse events in the escitalopram group did so in the first 12 weeks. 8% of patients receiving placebo discontinued treatment due to adverse events in the 24-week total period. Adverse events that were associated with discontinuation of at least 1% of patients treated with escitalopram, for which the rate was higher than placebo, were nausea, insomnia, and erectile dysfunction. So far for the 2 studies, for the major depressive disorder study and the obsessive compulsive disorder study, the main reasons people stopped taking the medication were nausea, ejaculation failure, erectile dysfunction, insomnia, and nausea. Most frequent adverse events. So adverse events that occurred in the escitalopram treated patients in the course of the short-term placebo-controlled trials with an incidence greater or equal to 10% were headache and nausea. The incidence of headache was higher in the placebo group, which suggests that this is a non-specific symptom related to underlying condition or treatment administration. The point prevalence of nausea increased during the first week and then decreased to approach placebo levels at the end of the studies. Okay, so now we have a table with all the listed side effects. And again, these are from these studies that we discussed above. And it shows the percentage of patients that experience these side effects on escitalopram compared to on placebo. Let's just go through this chart here and look at we'll forget about placebo, but we'll just look at the percentages of the group that were taking the medication. So heart palpitations, 1.4%, vertigo, 1.4%. Now with gastrointestinal disorders, so nausea, 15.2%, diarrhea, 8.4%, dry mouth, 6.6%, constipation, 3.5%, dyspepsia or upset stomach, 3.1%. Then we have abnormal upper abdominal pain and stomach discomfort around 1.1, 1.5. So continuing to move down, we have Fatigue, about 5%. Pyrexia, about 1%. Now, infections and infestations, so nasopharyngitis, under 5%. Influenza, 4.3%. Sinusitis, 2%. Gastroenteritis and herpes simplex, both under 2%. An increase in weight was 1.8, very close to placebo, so hard to really justify that. Decreased appetite, 2.4%. Increased appetite, 1.7%. Arthralgia or joint pain, 1.4%. Pain in the extremity, 1.4%. Dizziness, 6.3%. Somnolence, 4.1%. Sedation, 2.4%. Migraine, 1.5%. We have tremors, 1.5%. Lethargy and sinus headaches, both 1%. Insomnia, 8.2%. That's significant. Anxiety, 2.2%. Decreased libido, 2.1%, which is much higher than placebo. Inability to have an orgasm, 1.8%. Again, much higher than placebo. Abnormal dreams, 1.3%. Hyperhidrosis, so sweating, 3.4%. Night sweats, 1.7%. Rash, 1%. Hot flush, 2.2%. So reproduction system and breast disorder, so sexual side effects, ejaculation delayed, 3.6%. Notice here, placebo, we're all 0%, so these are significant. Ejaculation failure, 2.7%. Erectile dysfunction, 2.7%. Ejaculation disorder, 1.3%. The following events had a higher incidence in the placebo group compared to the escitalopram group: vomiting, abdominal pain, flatulence, upper respiratory tract infections, bronchitis, back pain, neck pain, and headache. Adverse reactions observed with escitalopram are in general mild and transient. I'll say that again. Adverse events observed with escitalopram are in general mild and transient. They are most frequent during the first and or second week of treatment and usually decrease in intensity and frequency with continued treatment and do not generally lead to a cessation of therapy. So typically your body gets used to the medication and the side effects do go away. In a clinical trial involving patients with major depressive disorder, that compared fixed doses of escitalopram, 10 or 20 milligrams a day, with placebo, the most common adverse events that occurred in patients treated with escitalopram are shown in Table 2. So the most common adverse events that occurred in patients treated with escitalopram are shown here. So diarrhea, 10% for 10 milligrams a day, 14% for 20 milligrams a day. Nausea, 22% for 10 milligrams a day, 13.6% for 20 milligrams a day. Insomnia, about 11% for each. Dry mouth, 11% and about 10%. Dizziness, about 10%. Ejaculation failure, so nobody taking 10 milligrams a day had ejaculation failure, but 7.3% taking 20 milligrams did. Nasopharyngitis, 5% on 10, 7% on 20. Constipation, 2.5% on 10, 5.6% on 20. Dyspepsia, 6% on 10, 4% on 20. And pharyngolaryngeal pain, 6% on 10, 1.6% on 20. Male and female sexual dysfunction with SSRIs. While sexual dysfunction is often part of depression and other psychiatric disorders, there is increasing evidence that treatment with selective serotonin reuptake inhibitors, SSRIs, may induce sexual side effects. This is a difficult area to study because patients may not spontaneously report symptoms of this nature, and therefore it is thought that sexual side effects with SSRIs may be underestimated. So table 3 here shows the major sexual side effects. So decreased libido, 2%. Inability to have an orgasm, 1.8%. Now males only, ejaculation delayed, 3.6%. Ejaculation failure, 2.7%. Erectile dysfunction, 2.7%. And ejaculation disorder, 1.3%. They also have tables here going through the studies for the obsessive compulsive disorder trial. We just went through the side effects for the major depressive trial. I don't think there's much use in going through the tables for both. So if you would like to go through these numbers, pause the video now, take a look at the numbers. Again, obsessive compulsive disorder, pause the video now, take a look at the numbers. They should be similar to that of the major depressive disorder group. Adverse reactions during treatment for up to 44 weeks. The treatment emergent adverse event incidence profile of escitalopram is a longer-term study in patients with major depressive disorder consisting of a 36-week placebo-controlled relapse observation phase in responders of a preceding 8-week acute treatment phase was similar to that observed in short-term studies. So even when the medication is used for longer term, the percentages of side effects still seem to be the same in those shorter trials. All right, so we're just skipping over some explanations of each side effect. Spontaneous adverse events, they would be very rare, so I don't think it's useful to go over those. Drug-drug interactions, I don't think would be very useful to go through from this monograph perspective. I think if you had any drug interactions, obviously they'll be flagged at the pharmacy. You can bring your medications to your appointment with your doctor. They can make sure there's no interactions. Check with your pharmacy. They'll check when you get your prescription. So going through all of these drug-drug interactions I don't think is useful. So skip through the drug interactions. Okay, dosage and administration. So general. Escitalopram should be administered as a single oral daily dose, with or without food. Again, I think we mentioned this before, but it is not indicated for use in children under 18 years of age. Recommended dose and dose adjustment. Major depressive disorder. Escitalopram should be administered as a single oral dose of 10 milligrams daily. Depending on individual patient response, an increase in dose to a maximum of 20 milligrams daily should be considered. Where initial sensitivity to adverse events may be a concern, escitalopram should be started at 5 milligrams daily and titrated upwards as tolerated. So that's where there's an initial sensitivity to adverse events. We're concerned about adverse events. We can start on 5 instead of 10. Obsessive compulsive disorder. Escitalopram should be administered as a single oral dose of 10 milligrams daily. Depending on individual patient response, an increase in dose of up to a maximum of 20 milligrams a day should be considered. Again, if we're concerned about side effects, we can start on 5 milligrams. During long-term therapy, the doses should be maintained at the lowest effective level, and patients should be periodically reassessed to determine the need for continued treatment. Elderly patients. A longer half-life and decreased clearance have been demonstrated in the elderly. Initial dosage is 5 milligrams once daily. Depending on the individual response and tolerance, the dosage may be increased to 10 milligrams daily. So elderly patients don't get up to the full 20 milligrams daily. We already discussed that there's no dosage adjustment necessary in kidney impairment. What about liver impairment. So dosages should be restricted to the lower end of the dosage range in patients with mild to moderate hepatic insufficiency. Accordingly, an initial single oral dose of 5 milligrams daily is recommended. Subsequently, the dose may be increased based on the patient's response and clinical judgment. A daily dose of 10 milligrams is the recommended maximum dose for most patients with hepatic impairment. I don't think we'll get into the enzymes. The long-term treatment just says use the lowest effective dose possible. Switching patients from a monoamine oxidase inhibitor, so wait at least 14 days after discontinuing the monoamine oxidase inhibitor before starting an SSRI. Similarly, at least 14 days should be allowed after stopping escitalopram before starting an MAOI. Decrease the medication slowly. If you miss a dose, just take the next dose when it's due. Don't take extra medication to make up for a missed dose. We won't go over overdosage. I don't think there's really much left in this monograph that's really pertinent to go through. Storage instability, not too important. Dosage forms, I mean, it's a tablet, 10 milligrams and 20 milligrams. Chemical structure there if you're interested. And then just more clinical trials. Yeah, the rest of it seems to be pretty just straightforward. Extra information if you're looking for it. So again, with these monographs, again, a monograph is a great place to go if you're looking for all of the encompassing information about the medication that you're using. You could get a monograph printed off at a pharmacy if you wanted. I'm sure they would do it for you. But any medication you're on, you can go on Google, type in the name of the medication, followed by monograph, and it'll bring you to one that you can get the PDF of. So like I said, that pretty much closes up this monograph review. I don't think there's much more important stuff on here to go through in this video. It might just be a little dragging on if we keep going on with it. So as always, thanks for stopping by. If you found the information valuable, you'd like to help grow this channel, remember you can like the videos, share the videos, and most importantly, subscribe to the YouTube channel. And we'll see you next time. Take care.